So in order to do that, we want to build on the strengths of what's currently going on. We want to understand and map the patient experience. Just like those questions sometimes give us a new insight, we want to actually map what does the patient experience for any particular process where they hit different points in the system. We want to be clear on how we communicate together and understand the current flow of information across the team and the information flow. Now, I think as we do this, though, because it's a system-level change, then there can be some threats and some tensions. And so it can feel a little bit like tug of war. Well, are we going to integrate, are we going to be a team my way, or are we going to be a team your way? And that can take a little bit of time and energy. And so that's what some of the teams have had to work through. Now, when we talk about teams, there are two different types of two elements to teams that I'd like you to think about. One is your clinical team, and your clinical team is the one that says, okay, what are the clinical needs of this population that we're serving? What is it that we want to get done? And then have the conversation about the operational team, how are we going to do it? And maybe the key point here is that in these stories, you'll see that the receptionist involvement, the clerical staff, if there's an administrator, as well as the clinicians, these are all key players in talking about both the clinical and operational aspects of how you do the work. So this is population focused. You are serving a population within your family health team, within your clinic environment. And so there is a roster, and you need to understand that population as well as possible. How many people? How often do they come? How often do you ask them to come versus they decide to come on their own? What kind of variation is there? How many phone calls come in? How many prescription refills? Who comes in? Who comes in the most often, and how can you better meet their needs? And what are the top 10 diagnoses, the demographics? You need to actually understand the population in order to figure out how your clinical team and how your operational team should move forward. So in some of the examples, I'm actually going to be pulling from examples mostly from Alberta, and I'm going to start with Tabor because it's so heavily researched and because there are so many tools and resources that not only came out of Tabor but spread across the region and then across Alberta, and I know actually into Ontario. So I think it's a good place to start, but I'm actually going to draw on some experiences other places, because a lot of these communities that have worked with these concepts are serving Aboriginal communities. They're up in Fort McMurray. They have a very transient population. There's a lot. Maybe they're in a recreational community where there's actually a lot of population turnover. So there's these are the communities that have really adopted some of these ideas and moved forward. Typical starting point is within the primary care office. There were a bunch of people, but they were in boxes. Everybody was in their own little box. They would send, and so they didn't talk very much to each other, and they did their own thing. They would send referrals to specialty programs, so whether that was a diabetes program or what have you, and they would send a bunch of referrals, maybe some clinicians would send a bunch of referrals, some not. And then they felt like there was a big black hole. There was a lot of rework and inconsistency then that happened between that. And then the community was off by itself. There wasn't really much connection there. So what happened in Tabor in the days of the pilot project was there was patients in this rural community traveled to 3 different sites for care. There was the lab hospital, the physician clinic, and the health center. And the health providers were spending way too much time playing phone tag with each other. And so there was a lot of overtime actually being paid for people to try to connect with each other on the phone. Does anybody here stay late to try to connect on the phone with other providers? Yeah, so that was, I mean, what an inefficiency when we think of the value of your time. And so there were 8 physicians. They were working faster and longer, but there was no relief in sight, and there was burnout going on. So in building on the strengths, then what they recognized was that though they had a lot of great resources, whether those resources were 2 hours away or an hour down the road or what have you, they did have access to resources, or some within the same community. But boy, they couldn't even keep a handle on all the referral forms that they had. What was current, what was old, how many, what was a single form, what was, oh no, you're supposed to use the 4-page form for that or the 2-page form for referral for this. And that was a huge barrier. And so they got together with those support agencies too, and they ended up coming out with a single-page referral form for a single point of entry. So they looked at what's going to work for the team. And so, so that was one huge transformation that made a big difference that spread because it was in partnership with others. They also looked for what else will support team-based care. So they said the other thing that would support team-based care is that algorithm sheet, that patient care flow sheet that Mike was talking about. So there, within that organization, they ended up leading a process together with the regional programs to say, you know, we do need interdisciplinary clinical guidelines. We each have our own discipline-specific guidelines, but we need something that pulls us together. And so they did the work participatory and got those. They came up with the big binder, and just as Mike said, then they said, that's great. The process let us buy into it, but we're not interested in this big binder. So it comes down to what's the one sheet that every discipline is willing to work from to figure out what their role is in relation to the care flow. So they came up with those related to all the clinical disciplines and spread those then across the region. And those, the Canadian Family of Physicians actually, or CFPC, has actually got that on their website if anybody's interested in those. They looked at mapping to understand what was going on, and that's as simple as Post-it notes. You know, just map out what is happening in that patient's journey. So when we did that with Well Baby, we recognized that, in fact, the patient was having duplicate visits 4 times in 1 year between public health and physicians, and they were being asked the same questions. So, and that was a simple Post-it note exercise. What are we doing? How can we fix this? So this is actually an example of what a Post-it note exercise ended up looking like for the team to make plans from. And this is a clinic with 1.5 FTE. So I don't want you to think, oh, you know, that's like a lot of work. This must have been a big resource-intensive thing. This is a rural community, 2 hours from the nearest center, 1.5 FTE physicians, and an RPN and a clerk. That's what they had, and they had an administrator. So they looked at this, said, what typically happens, where can we actually implement some changes and bring in some other roles? So when you're looking at the flow, whether it's between the physician and the diabetes educator, or whether it's a referral between the family practice center and a specialty program, you need to understand the work that's being sent. What's being sent, how much? Is it being sent in the same way, in the right way, or are you wasting energy by having to do rework? What is the expected communication, and how do you want to communicate with this group? So having those conversations was very, very helpful. The communication routines that Mike talked about were also experienced by these groups, where they said, you know, we have to sit down at a table together and talk. And we have, because sometimes, because we don't understand what the variance is about. We don't understand why there's not consistency. And so by having that conversation, they were really able to get down to what they wanted to happen consistently. The weekly improvement meetings, daily huddles, and that moving to a place where instead of training the dietitians all together, and instead of training the physicians all together, the team would train all together. Tabor actually uses an EMR to manage the patient registries for high-risk populations and chronic conditions. And so all clinical staff, the whole team, have access to the EMR both on-site and off-site. And let me tell you, that was not quick. And but once you see it can be done, it can be done. And there was a certain principle related to the EMR. It was no clinician will double enter anything. As we're moving towards trying to figure out how to have shared communication, they set a principle saying no clinician will ever double enter. So we have to figure out how to make shared communication work so that there is no duplication by clinicians, and that's what they did.